Good morning. I'm Dr. Deuk and I'm here with my A-team at Deuk Spine Institute, Surgery Center of Viera, here in Melbourne, Florida. It is December 21, 2023. This is our last day of operating in the calendar year of 2023. Is that right? Our patient here comes to us with back pain. He's had back pain for how many years? Over 20 years. And we believe the pain is coming from two discs in the lower back, L4-5 and L5-S1. So we're going to go in there and we're going to repair those two discs. Our patient is just awake. He's sedated a little bit, but he's still awake, so he can help me navigate properly to his disc. This surgery is the least invasive spine surgery that you can possibly perform. There is nothing less invasive. There are needle-based procedures that we do in spine, but they're not real surgery. Surgery involves an incision. This surgery requires an incision. The incision will be small. It will be approximately 7 millimeters. It's tiny. All right, I'm hitting the iliac crest. I may have to redirect. Let's just see. You're fine. Let's give him a little more numbing medicine. You're doing great. The most important part of this surgery, in my opinion, besides the anesthesia, is to place this needle exactly where you want it to be. And it has to start in the perfect spot on the skin, and it has to end right where the herniation is in the disc. And that's what we're trying to do. But along the way, it cannot pass through any area that you don't want it to pass through. So that's the navigational part, where you go from a starting point to an ending point, and you don't go through an area you don't want to go through, okay? And the reason is, inside the human body, there's lots of vital structures: intestines, kidneys, ureters, blood vessels, muscles, and you want to make sure you're passing through the right things. Perfect. So, as a matter of fact, let's just take that picture right there. Do not change it. Henry, can you see the x-ray?
Yes, we can.
All right, do you folks see this tip of the needle? And then the shaft of the needle. And we're aiming right towards the disc. Show us where our target is. Yes, right there. That's exactly where we want to be, where Jordan has the arrow. Now, look at the needle shaft. There's this thing that looks like a cloud, like cumulus nimbus. That's the intestine. That is the colon, full of air. Okay? Now, it almost looks like we're passing through it, but we're not. That's what I mean. Along the way, there are some areas you want to stay out of, like Big Stinky. We call the colon Big Stinky, okay? Point is, you want to avoid those areas. So, that's why I make this look easy, but in reality, there's a lot of treacherous possibilities along the way. And I need his help navigating there. He's going to tell me if I get too close to his nerve. That's the one thing that I can't really see, is the nerve. I know where it's supposed to be, and I can stay away from it as much as possible. But everybody has a little bit different placement of their nerve. We call it the nerve root. It's the L5 and S1 nerve root in this case. You doing all right? I can feel the herniation right here. I'm bumping against it. So I'm pretty happy with that. Let's get another AP view. I want to make sure we're right where we need to be. So once again, the reason why the patient's awake is to help me navigate safely to his herniation. Perfect. We're right at the back of the disc in the foramen. We're coming through a natural opening in the spine. There's no blood vessels here. It's perfect. If I pass through this whole path with the rest of the surgery, it's safe. now that we know exactly where our entry point will be on the skin, I can give him a little bit more numbing medicine. We stopped using epinephrine in our numbing medicine because it was causing patients to have their blood pressure go up, which epinephrine does that. And it's been used in the injections for many years because it stops bleeding at the level of the skin, right? So if you put epinephrine here, it actually narrows the blood vessels so you don't get any bleeding when you cut the skin, or you minimize it at least. But we found that it was quickly raising the blood pressure and the heart rate, and we didn't want that. So we decided to take it out of our injections. And as a result, my anesthesiologist is a lot happier. Okay, we're placing our second needle. Let's go ahead and show our audience, Henry, why do these disc injuries, why do they cause so much pain for people? AP? Well, now you understand why the disc can be so painful. You get a tear in the back, it gets inflamed from the herniation. Your body's attacking the herniation, trying to get rid of it. That's where all the back pain comes from. That's what we treat with the Deuk laser disc repair. Now, this is the blood loss for the entire surgery. The alternative surgery to the laser surgery repairing these two discs is for me to make an incision like this, about 10 inches, and to peel all the muscle and skin off the spine, and then to go in and remove all the bones and ligaments and take the discs out, put in cages filled with cadaver bone, and then screws and rods to hold everything together. We used to do that surgery and it works great. It will get rid of the pain as well. But why do all that when you can do the whole surgery through a 7mm incision and lose about 6 drops of blood? All right. He's ready?
How you doing, my friend? We're going to ask you a pain score, okay?
Now, when I asked him, where is your pain, he said it's in here, right? Across the back here. You okay? Any pain?
Yes or no? So you have any pain?
No. See that? He jumped up. How bad is that on a scale of 1 to 10, Shot?
What's the number? 10.
10. All right. Is that where you get your back pain? Yes? All right, good. So he has 10 out of 10 when I injected the L4-S1 disc. By the way, the amount of pressure I'm putting on that is no different than me just pushing on my hand like this. If I push on your hand, will you have pain that's 10 out of 10? No. So the fact that he has 10 out of 10 pain with just a little bit of pressure in the disc tells me that disc is his painful disc. So we have a positive discogram, L4-S1, 10 out of 10. Is the pain better? You see that his blood pressure spiked with the pain, and we got like 2 more drops of blood. So we've got 8 drops of blood, I think now, or close to 10. Is that better then? All right. How bad is that on a scale of 1 to 10? All right, is that where you get your pain? Sorry about that, we're all done. We found your two bad discs. Congratulations. We're going to fix those. How long have you had back pain? Over 20, folks, 20 plus years of back pain. And guess what? We're going to get rid of it today. Count from 1 to 100 out loud so we can hear you, my friend. So, I want to tell you a story, folks, while we're waiting. Deuk Spine Institute has done the research on our patients, and we found, as I reported to you, 85% of our patients have pain from discs as their primary major cause. This is the first report in the history of man that has ever documented where back pain comes from, specifically, and the percentage, what's called the relative frequency. The second most common reason is the facet joints. Everything okay? That's about 10%. So 95% of chronic back pain comes from discs and facet joints, which we treat all the time. I submitted this to a Southern Neurosurgery meeting for them to allow me to present it to all the neurosurgeons and the results of our laser surgery. They have come back with a decision about our research and our results, which is historic, by the way, and everyone should have these results available. And their decision was to reject allowing me to present the data to the neurosurgeons. This is an example of just how controlled neurosurgeons are by the companies that manufacture implants. They do not want any outside information. They don't want endoscopic surgery. They don't want surgery that doesn't involve hardware. So by allowing me to present our endoscopic laser data at the meeting, it will take away their business of putting screws, rods, cages, and spinal cord stimulators. And these companies control the agenda. They're the ones donating millions of dollars for the meeting so we can go to a nice hotel and have nice meals and have a vacation while we go and learn new stuff. Of course, they only want us to learn the things they want us to learn, like new screws and new rods and new metal to put in patients. And I am just disgusted, to be honest with you. But it's eye-opening, and it's what I've been saying for years. The industry controls the flow of information to doctors, and they only want doctors getting information that they approve, which is information that promotes their products and devices to be implanted into patients. They are against any new information that would help patients stay away from needing invasive treatments. It's a multi-billion-dollar industry, folks, and it has completely overtaken the actual science of medicine and replaced it with business, big business. And it's not just in spine. This is everywhere, in everything in medicine. These companies have completely infiltrated our educational system, our universities, our meetings, our national meetings that are supposed to be scientific agendas. It can't be scientific if you're not telling people the truth. Anyway, it's a bit disheartening, but we're going to have to find another avenue to get the word out. One that's not controlled by the biomedical industry. I do want to note that this is a very patriotic patient. You can see he bleeds red, white, and blue. All right, Henry, any questions from our audience?
Yes, we have a couple questions. This first one comes from Big John on YouTube.
Big John, I'm waiting for your thumb. Where is your thumb?
They asked, good morning. I might not be asking this question correctly, but can you explain what are/is myotomes versus dermatomes?
Sure. Yeah, so Big John is wanting to learn more about myotomes and dermatomes. It turns out the 5 nerves that leave the spine in the lower back, they're called the lumbosacral plexus. They're nerve roots that go down to specific areas in your leg. For example, the big toe gets its nerve supply from the L5 nerve root. The little toe from the S1. Okay? Now, just remember though that every human being is different. We're all created individually in our mother's wombs or father's wombs today. I'm sorry. I couldn't resist that one. And sorry. Anyway, while the embryo is developing, the nerves are formed and they grow down to your legs as your legs form. But they don't follow the rule book all the time. So they don't always go exactly where, you know, the last person's nerves went. So there's some variation, okay? So when you look at these charts that they're called the dermatomes and myotomes, they're basically the areas in the leg or the arm or the trunk of the body where you expect that specific nerve, let's say the L5 nerve root, to go. You expect it's like a root, right? If you plant a tree in the ground of your garden, where do you expect the roots to go? They're supposed to go down, right? Straight down. So you would expect the growth of those nerves to be below the tree. And they are, for the most part. But trees do funny things, right? If the water is actually 100 yards to the north, there's more water in the soil, then those roots are going to grow more towards the 100 yards to the north. So they're not going to grow straight below the tree. They're going to go off in a direction that they're stimulated to go to based on the availability of water in the soil or nutrients like minerals. And it turns out with trees and roots, we thought we understood it all, but we don't. It's new information that shows there's an interaction between tree roots and basically, what is it called? Mushrooms, rhizomes, oh my God, I'm drawing a blank. Basically, I'm thinking mycotic. It's basically all the organisms that don't rely on photosynthesis, but they decompose. They're decomposers, like mushrooms, okay? Anyway, it turns out that the growth of roots, even in trees, is not as simple as you'd like to believe. So, of course, the growth of roots in the human, as you're developing embryologically, is not so simple either. The L5 pretty consistently goes to the big toe. So what that means is a dermatome is the skin, right? Dermatology is skin. So what they're talking about is on your skin, if you touch your skin in a certain area, we believe, based on lots of dissecting of humans and anatomy and blah, 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 experience, that certain nerves go to certain regions of the skin. Remember, in your lower leg, there's 5 nerves that go from your hip down, and so those 5 nerves kind of take their areas of skin that they innervate. So if you touch your skin, say on your big toe, then the feeling of touch goes up the L5 nerve root, branches up to your brain. So it's transmitted along the L5 nerve root, okay? On the other hand, if you touch your little toe, your pinky toe, that's the S1. So that's the next nerve root that comes out, the S1 nerve root. So that's dermatomes. Dermatomes is about innervation of the skin and sensation in the skin. Myotomes are muscles. Myo is muscle. So the myotomes refer to which muscles in your leg are innervated by which nerve roots. Remember, there's 5 nerve roots. There's L2, L3, L4, L5, S1 that go into the leg and innervate the muscles in the skin of the leg. And it's true for everybody. So if you see weakness in a specific muscle, then you can say that may be the nerve root to that muscle that is the reason why you have knee weakness. It's affected. The nerve root's affected. It's being damaged somehow or compressed. Okay, and we call that a radiculopathy. Radiculopathy. Pathy means pathology. Radiculopathy is pathology of the nerve root. So if you see a patient who has numbness in the big toe, that's an L5 radiculopathy usually, because the L5 dermatome involves the big toe. It's basically the skin innervated by that L5 nerve root in the leg. And then if you see weakness of the tibialis anterior muscle, which is a muscle that cocks your foot up, and your toe, basically your toe up, and a little bit of your foot up, that's the L5 myotome. So if a patient has weakness with cocking their foot up and they have numbness in their big toe, then they probably have an L5 radiculopathy. So you use the myotome and the dermatome maps to figure out which nerve root is affected. Next question.
Next question comes from Donald on YouTube.
Donald on YouTube, welcome to our live stream.
They asked, Doctor, I've seen the term BMP. Can you tell me what that is and if you use it?
PMP. There's PRP, which stands for platelet-rich plasma. Basically, they take your blood, they spin it down, and they separate the red blood cells from and the white blood cells from your plasma, which is basically the water of your blood that contains nutrients. That's what PRP is. Do we use it? Absolutely we use it, but it doesn't work in disc problems. We've tried it. It costs a lot of money for the patient to pay out of pocket, and we don't believe in doing treatments at Deuk Spine that don't work. So we don't do PRP for disc problems. We do it for joint problems like hips and knees and shoulder joint problems because they tend to respond better to PRP treatment. You actually get a good result with PRP if you inject it in certain places, but you don't get a good result if you inject it in others. Since we treat disc problems, facet problems, piriformis muscle problems, other muscle problems, joint problems, knee problems, hip, shoulder, fingers, wrists, ankles, since we treat all those things, we could technically put PRP in any of them, but in reality it doesn't work in all those things, you know, where people get pain. So typically PRP is injected into areas where there's inflammation, and it usually can end the inflammation. People have tried injecting it into discs, but it doesn't work, and it doesn't last. The pain always comes back. Deuk Spine Institute is interested only in treatments that work and last. Both of those qualities must be present for us to recommend a treatment. Now, some people and a lot of insurance companies will only pay for treatments that don't work and don't last. That's all they pay for, treatments that don't work and don't last. Why? It makes no sense to me, but that's insurance companies for you. Usually because the don't work and don't last treatments are cheaper, mostly, but not always. Why they don't pay for PRP and stem cells, I think that they just don't want to spend the money. And I don't blame them. Honestly, I wouldn't either. I wouldn't want to pay for those either because they don't work and they don't last. Is that what he was referring to as PRP?
It says for the term BMP, like B as in boy, M as in Mary.
What?
He said he's seen the term BMP, B as in boy.
Oh, BMP.
Yeah.
Sorry, BMP is bone morphogenic protein. It's used by fusion surgeons to promote fusion. It's been around for over 20 years. And the problem is BMP causes a lot of bad things to happen. It eats your bone up when it's not supposed to. It causes bone to form in places it's not supposed to, including around the nerves. So it can cause nerves to be pinched and nerves to be damaged. I do not recommend using BMP. I used to use it back in the early 2000s, like around 2000, 2001, 2, 3, 4, when it was, okay, so there is some use to it if you have a patient, for example, that has bad bone metabolism like osteoporosis, and you want to do a fusion, and you want to improve the bone healing, then BMP could be used. But there's so many complications from it that I do not recommend it. And by the way, you're not going to find those complications looking for them online, because the company that sells BMP is hiding all those complications. They basically spend a lot of money to bury the complaints about BMP and hide them on Google so you can't see them, okay? They spend millions of dollars doing it, and it works. They hide those things from you guys so you can't see it, okay? But BMP is bad stuff. And I used to use it, and it's come out very clear after years of using it by many doctors that it has some really serious complications. And I found it to be unnecessary for patients to have it. I mean, if I felt it was beneficial and it would help, then I would use it. But I don't use it because it doesn't help the patient. It doesn't help me. It only helps the company that sells it and makes millions and millions of dollars selling it. Okay, we're done with our first disc, and you can see the hole where the herniation came out, called the annular tear. And that's it, right there. Now, the inside of this tube is about 5.5 millimeters. And you can see that this hole is about 3 millimeters. So that will close up over time. But notice the white color of the tissue. It's white because it doesn't have much blood supply. The disc does not have a good blood supply. That's why it heals so slowly. So slowly. Which is why we tell our patients, you have to wait a year before you go out and do everything you want to do, like no restrictions. Now I'm going to tell you something. That hole will never heal with a microdiscectomy. That hole never heals with a laminectomy, because laminectomy and microdiscectomy do not fix the hole where the herniation came out. The Deuk laser disc repair is the only surgery that does. And other companies have tried selling things like the barricade device or disc seal, but they don't work. We have tons and tons of patients that get those things done, and then they come here and they're in worse pain than they were before. So those procedures never seem to work at all. Don't waste your money and time or take the risk of having that procedure done. It's unnecessary. You can see why other spine surgeons, neurosurgeons, industry don't like us, because we're doing something better for the patient that they can't do. They don't know how to do it, they're not trained to do it, and it doesn't make money for them. They would basically be doing it for free compared to what they're doing now with spinal cord stimulators, barricade device, disc seal, epidurals, facets, fusions, artificial discs. All those procedures pay very well to the surgeon, the hospital, and the company that sells the devices. However, they don't work for the patient. But doctors promote that because they make so much money doing it. We, on the other hand, do procedures that don't pay very well, but it's better for the patient. And it lasts. And that's really the big difference, folks. That's why our work is not accepted at meetings or promoted at meetings, because the meetings are no longer scientific meetings. They're marketing meetings. And the sooner you folks learn that, the better off you'll be, because there's nobody out there looking after you. The government's not looking after your interests. The insurance companies are definitely not looking after your best interests. The doctors, unfortunately, are not looking after your best interests. And the companies manufacturing all these devices are not looking after your best interests. They're one of the worst barriers to new technology that doesn't involve implants. And you're only going to hear it here, by the way. And the only reason I'm able to tell you this is because I'm paying for this message out of my own pocket for you all to know the truth. And the reason I do that is because I feel it's unjust to civilization and humans. It's inhuman for you guys to be tricked and lied to and used as basically a money-making machine for greed and greedy companies. And I'm totally against that. I don't have a problem if the greedy companies told you, hey, we're going to recommend this surgeon put these screws and rods in you because we make a lot of money having him do that, but you're going to have all kinds of problems from it. If they came out and told you the truth, I wouldn't have a problem with it. The problem I have is that they don't tell you the truth. They lie to you. They make you believe that they're laminectomies, microdiscectomies, fusions, artificial disc, disc seal, barricade device, intercept device, interspinous device, just you name it, 100 procedures. They make you believe that that is what's best for you, but it's not. They're the same people that made you believe that drugs were best for you. I'm all the way in. I'm up against the disc. Yeah, it's the disc that's bothering him. Shot? Yeah, I just got to... It's fine. It's only for this brief second here. All right, perfect. Yeah, that's the worst part right there. We were actually pushing the herniation back in. And we're going to then remove it from inside the disc. My point is, folks, you guys are doomed. Honestly, I hate to say it, you're doomed without Deuk Spine trying to help you. I think there's maybe a couple of other doctors out there trying to raise the warning to you, but not many. And there's so much money in play here with these companies, billions and billions and billions of dollars, that, you know, politicians have been bought off, insurance agents have been bought off, lobbyists have been bought off, everybody's bought off. And in the end, the patients are suffering from all these spine surgeries that are unnecessary and don't work and put people in more harm and more pain. So, all right, Henry, let's go ahead and show the video of how the Deuk laser disc repair fixes disc pain. Laser. And welcome back. sorry to be such a downer at the end of the year, but folks, you guys need to know the truth. No one else will tell you. The entire spine industry is controlled by money and greed, by big companies that are just out of control, folks, out of control. All they want to do is keep making new products to put in you and charge more money. You know, when I read about Neuralink, I'm sorry, Elon Musk, but I'm a neurosurgeon and I used to work in that area. I read about Neuralink and I thought, this is freaking crazy. Okay, it is crazy. I would never put a chip in my brain, not just because it's unsafe, but because it doesn't work. You can't have computer-brain interfaces that involve electrodes penetrating the PIA do not work. Yeah, but, you know, the problem is, and I like Elon, I think, from what I know of him. I don't know him personally, but I mean, I would never sell something to people that doesn't work, right? But it seems like it's just possibly a big tech, you know, pump and dump opportunity like so many of them are. You know, get people excited, people with lots of money that don't know what to do with their money, they're kind of stupid, and they rely on the scientific ones that will lie to them for a buck. And so I know very much about these types of electrodes. I used to put them in rabbit brains to study seizures. For those of you who don't know my background as a neurosurgeon, I almost went into functional neurosurgery. I was a functional neurosurgeon, not almost. I was studying epilepsy and brain activity and electrodes, and I've implanted hundreds upon hundreds of electrodes in patients' brains for seizure disorders. And I did a fellowship with NIH in seizure disorders. I was funded my own grant when I was a neurosurgery resident, which is almost impossible to achieve a grant from NIH for your own research for 2 years on studying epilepsy in brains. And I did a lot of epilepsy research, a lot of surgery, and I could tell you that we have not found a way to prevent the scarring, the glial scarring that occurs when you puncture through the PIA. Those electrodes sit there, you know, within columns of neurons, and then this whitish membrane forms around them, you know, almost immediately within a few days, and it makes the electrodes not work well, and the impedance goes up, and so they haven't solved that problem, number one. Number two, so what if you can put an electrode and record some neuron activity? Big freaking deal. We've been doing that for many years. You know, whether it's single neuron recordings, just look it up. We've been doing this in the lab with neurons for years. Probably almost 100 years, probably at least 80 years. That doesn't mean you can actually interact with the neurons and exchange information with the neurons. So what exactly is this chip really going to do? Anyway, we're getting off of the spine topic, but I'll be happy to take your spine questions. We're back, right, Henry?
Of course, yeah.
Yeah. I've got probably 4 minutes left, so if you have questions, type them up. I'll be happy to answer them. I'm just talking about the chip, the brain chip that Elon Musk is developing, the Neuralink. And if you have questions, I'll try to answer them for you. But if you have spine questions, I'll take those as well.
This next question comes from Gordon on YouTube. And they asked, hi, as you remove the herniated disc material that you protruded through the posterior surface of the annular tear,
Yeah.
where does the irrigating solution go that you are using?
Ah, great question, Gordon. Yeah, it comes out of the tube, Gordon, off the top. I'll show you in just a moment. We'll turn on the lights. Let's go ahead and turn on the light real quick. Can you see this here, Henry?
Yes, we can.
Can you see the water coming out here, the irrigation?
Yep. Yes, we can.
All right, that's how it gets out. And it brings with it lots of little pieces of herniation. All the little pieces that we're breaking up with the laser. Great question. Yeah, we wouldn't want to break the herniations up into little pieces and then leave them in, because then we would be back at square one. It's the actual herniated fragments that are causing the inflammation to occur. They're stimulating inflammation to occur. So we want to get rid of them. We want to remove them from the patient's body. Yeah, you see them right there? They just took off and they went up. So the irrigation I'm using has several purposes. Number one, it removes the fragments of tissue that we're removing with the laser. Gets it out of the body, takes them up the pipe. Number two, it keeps the tissues cool. It keeps the laser tip and the tissues cool. Otherwise, if I just use the laser without irrigation, then there would be a fire inside the body. It would be bad. Just like any surgical instrument, if you don't use it properly, it can harm the patient and the people in the operating room, right? So the laser is no different. It's a tool, has to be used properly. 2 minutes. And the third thing the irrigation does is it keeps my visibility so I can see things. Because if I didn't have the irrigation cleaning everything out, then the water would be, or this tube would be very cloudy, and I wouldn't be able to see anything. It would be filled with blood and debris. So what allows me to do the surgery is the fact that the irrigation is removing all the dead tissue debris, like all this stuff right here. It just happens so fast it's hard for the human eye to see. But if you actually slowed this recording down, you would see chunks of tissue floating up past the camera, past the end. Just about done. The concept of surgical debridement is not new. It's something that's been around for hundreds of years in patients that have wounds that don't heal or tissues that don't heal. The surgeon has to go in and remove the devitalized, we call it devitalized, you might call it dead tissue, and that's what we're dealing with here, devitalized tissue. This devitalized tissue is causing inflammation. Any other questions, Henry?
Yes, this next one comes from Dan on YouTube.
Dan. Very nice to meet you, Dan.
They said, I sent MRI on lumbar spine showing spondylitis at L2 and stenosis. Can that be fixed? Was told you needed more current MRI. Please have someone contact me. Want to pay.
Yeah, so first of all, I appreciate you asking. The MRIs we use are always within a year and a half. So if you have an MRI that's a year and a half old or younger, we can use it. Second of all, yes, we can fix your back with spondylosis, spondylitis, not a problem. But I do need to see the MRI. I will give you a phone number you can call. Talk to Sam. She's our MRI review person. She can tell you if we received your MRI, and you have to fill out the form, so I hope you did that. If you have not filled out the form, we can't do an MRI review. We have to have your name, your phone number, your email, and what's wrong and how long you've had problems, etc. So all that's important. Sorry, Dr. B. There's one stubborn piece of herniation right here that's just super scarred up. Let me try to grab it out. So yeah, call Sam. Her phone number is 321. Henry, will you put this down?
Yes.
775-1299. 321-775-1299. And just tell her you sent your MRI in. Oh, that's a biggie. That's a beauty. Yeah, we just took that giant chunk out. That was nice. And just tell her you sent the MRI and give her the information. Then we'll set up a MRI review. The MRI reviews we do are free unless you've had some craziness happen. And we do one free MRI review per person. if we, obviously we can't do every body part free MRI review. It's not possible. I would be in a MRI cave all day and never fixing people. So we limit it to one freebie. My advice, pick the area that bothers you the most, your neck, your back, and then let us fix it. By the way, one last thing I want to say before we leave, because we're just about done here. And I will answer your questions, by the way. Type them up. I'm going to come to the conference room and answer them for you. We just completed our 4th piriformis release at Deuk Spine with a new technology called the Deuk piriformis release. It's minimally invasive. It's the least invasive piriformis release. It's outpatient. If you have piriformis syndrome, where you have a torn butt muscle and it's hurting you, we can actually go in and fix it surgically permanently. So it's a one and done. That looks good. All right. All right, Henry, when you get a chance, take a look over here.
Copy that.
Can you see all the little pieces of herniation here?
Yes, we do.
Those came out of the tube with the irrigation. So that goes back to, I don't know if it was Jordan or Dan's question? Gordon.
Yeah,
He was asking what happens to all that debris. It gets irrigated out. All right, folksies, we're done. And let's take a look at the incision. You did great. He's clamping down on the tube. You can feel his muscles tightening up. He's light, so he's pretty much awake. We're done. All right, take a look at this incision. Oh, we hit 1 cc of blood loss. Dang it. Do we have a stapler?
Yes, sir.
So I'm going to put a little pressure. That keeps the muscle from bleeding. And then we're going to put a staple in here. But I'll try to show you the incision real quick. Where's that big piece of herniation? It's already gone? All right. No problem. Here, let me have the stapler. Let me see. There's the incision, folks, right there. Can you see it?
Yes, we can.
So tiny, tiny incision, and I'm going to put a staple here. We'll take the staple out tomorrow and put a steri strip. Those are my initials. In case you're wondering, go ahead and type up your questions and I'll answer them for you. Great job. Thanks, everybody. And Henry, I'll come over and answer questions.
Copy that.
And good morning, I'm Dr. Deuk Majan here at the Deuk Spine Institute with a patient who's traveled 10 minutes from Merritt Island, is that correct?
I'm in Vieira.
Oh, Vieira, just down the street. Okay, local. You just had the Deuk laser disc repair on your lower back yesterday for a herniated disc at L4-S1. It was a foraminal herniation, and it's one that is tough for doctors to find and discover, but we saw it at Deuk Spine, and you were having horrible back and right leg pain. That was yesterday before your surgery. Here you are less than 24 hours later. How do you feel?
Wonderful. Walking straight. I feel no leg pain, no back pain, just a little sore, but that's about it.
How long have you had the back and leg pain for?
Since 2012, 2013, since my surgeries.
You live with pain.
Right.
He had, I guess, a microdiscectomy done.
Correct.
Did that fix him?
No, a month later he was back in surgery.
What kind of surgery did you have done?
The fusion, S1, L5.
So you had an L4-S1 fusion, good. Did that fix your problem?
No, not at all.
And their suggestion was take the metal out, and that they already seen that he had a problem with the disc above that one, so let's take the metal out first, then within a year go back and do another fusion on the disc above that.
And that was the metal they put in you.
Yes, sir.
So they put metal in you for the fusion, and then they told you afterwards, well, we got to get it out because that's what's causing your pain.
Right.
Kind of silly, isn't it?
Yes, sir.
All right, glad I'm not the only one that thinks that's a bit silly, but that's right, it is silly. And it's not just the surgery, the fusion. Didn't you have pain management and stuff in between?
Yeah, so I had shots and a nerve specialist do some stretchings and hands-on stuff, but that's about it.
So you had shots, you had therapy, and then you had surgery, and you had more shots and therapy. And that's the problem is you're like I think about it as like a washing machine
Yeah.
going around and around, and they're just washing the money out of your pockets and washing your life away because your quality of life has not been good, has it?
No, not at all.
How did you find Deuk Spine Institute?
My wife.
I couldn't believe it. Amazing. Last time he had surgery, 9 days he couldn't even hardly move. And I mean, he was up last night pacing the floors, antsy, trying to find something to do.
This must cost your family a lot of money dealing with the pain. Over
Oh
all
yeah,
these
well,
years.
and it cost him not just with the pain. He was not able to do the stuff he likes, fishing, throwing the baseball with our son. So just just doing life things is not. He's not able to do that because of all the pain that he goes through. So now we're just so grateful that we found you guys because I mean I have not seen him walk like this in 19 years.
And that's just one night.
Yeah, that's just one night.
And
so
no pain meds.
no pain meds, no anything, no medicine. He had took no medication whatsoever last night.
So just to recap, your husband, like millions of people, had back pain. He went and had microdiscectomy, which is a procedure where the surgeon basically ruins the back of the spine in order to get to the disc. That caused instability, which then he needed a fusion done shortly
Correct.
afterwards, right? You
Yes.
said a month later?
Yes, a month later.
And then you went back again because he was still in pain and worse after the fusion.
Right.
And they told you he needed another surgery, a third one,
Correct.
to get the metal out.
Right.
And then he was going to come back for another fusion after that.
Correct.
And then there would be more fusions and more fusions, right?
That's never ending.
Never ending. And we see this all the time with people that have open back surgery, invasive back surgery is a cycle of over and over, more and more surgeries. Well, he's done now.
Yes, thank you. And we're so grateful.
We
You just
have
don't
one
know.
more muscle thing to fix and then we're done.
Yeah, you might have to do something to me so I can keep up with them.
You ended up having faith. You had the surgery done yesterday. You can see in the video, we made a tiny little cut, just 7 millimeters on your back, and we got the whole surgery done. We found the herniation, we cleaned out the tear. And while you were in there, I tested your disc at L4-5 above your fusion, the one that's bad. You had 10 out of 10 pain. And I asked you, is that your typical
I
back
heard
pain?
that.
Yeah, and you said yes. So you're gonna watch your surgery today. We gave you a video. Henry did a great job recording it and broadcasting it. But you're happy today. You've had your back fixed.
So I'm walking straight.
You're walking straight.
Walking straight, not leaning.
And do we have you on pain medications at all today?
No, nothing.
You didn't take any, did you?
Nothing.
You didn't need it?
Zero, nothing.
Yeah, with the cut on your back being that big, it's a Band-Aid. There's no trauma inside your body we're doing, so there's no need for pain pills. That's one of the nice things about Deuk laser disc repair compared to open back surgery like fusion, is that we don't do trauma inside your body. There's no need for pain medicines afterwards.
The fusion caused hernias, and
Mhm.
I had a hernia surgery.
Really?
Yeah, because of the pain pills.
So all the complications from fusion, including, I've not heard that one, having to have a hernia surgery on your groin, right?
Mm-hmm.
Wow. So there's another complication from
Yeah.
fusions. Well, you're not going to have that problem anymore, are you?
No, sir. Hope not.
Well, is there anything else you want to share with your fans out there who are listening to your story?
The best thing that's ever happened to me. I'm walking straight, no pain. I feel like I can go do what I usually do, and especially fishing.
Yeah.
I miss that.
We're going to get you there. You're
Thank you,
welcome.
dude. Thank
It's
you.
my pleasure. Get back to fishing.
Yeah.
I just want everyone to know, please make sure you educate yourself before you do this because, you only have one life and you want to make sure you live it to the fullest, and doing these back surgeries that these doctors recommend is not the way to do it. You need to come here And I mean, at least just give it a shot. Let them look at your MRI. I think you said you can do the reviews online if you
Free.
don't, you know, out of state. But please check here first and let Dr. Deuk, you know, go through all of your records, because I'm telling you, this is the best thing that we've ever done.
I'm happy for you guys.
Oh, thank you so much. You just don't even know how. Like, I couldn't believe it. My son was like, Dad, you're supposed to be laying down, and he's in there walking around. Like, we couldn't keep him in bed last night. So it's amazing.
Okay, great. That was such a nice testimonial. Thank you, Henry. We've just completed in a patient that has had 20 plus years of lower back pain. 20 years. Coming from 2 discs in his lower back, and we just got rid of that pain after 22 years. It took us literally an hour, and it was all done through a 7mm incision. And now he's going to walk out of here without that pain in about 2 hours from now, or an hour, however long it takes him to recover. And I'm hoping to have a nice testimonial tomorrow morning for you, like we have so many. It turns out that about 50% of the patients will leave our facility an hour after their surgery, and they have 0 pain. The other 40% on top of that 50, to make it 90%, will leave the next morning to go home. Not from our facility, but from their hotel, and they will have their pain gone. About 10% of our patients end up having some aches and pains that's residual, that go away over time. And about 20% of our patients develop pain in other areas where they did not have pain when we saw them in the beginning of surgery. But that is another area that had arthritis that just was quiet, and we didn't know about it. We cannot fix pain that we don't know about. If you have wrist pain, but it's not bothering you every day, it only happens every couple of days or once a week, well, if we don't know about it, we can't fix it. So the back has 30 causes of back pain, 30 specific individual causes of back pain. And some patients have 2, some patients have 4, some patients have more. It turns out that the average patient is going to have 4 causes of back pain. That's 2 discs and 2 facets, or 3 discs, 1 facet. I mean, different combinations. Those pain sources include the piriformis muscles, there's a right and a left, the SI joints, the facet joints, and there's 5 on each side, the 5 discs, the vertebral bodies, which can fracture, and the coccyx. Those are the most common causes of chronic back pain, the most common being the discs. Discs account for 85% of chronic back pain as the major source of back pain. The facet joints being the other 10 to make 95%. The last 5% of chronic back pain comes from the piriformis muscles, the sacroiliac joints, the coccyx. Rarely do we see fractures, not often. So all these causes of back pain are totally fixable today at Deuk Spine Institute, not everywhere else, okay? When we say they're fixable, it doesn't mean you can go to any surgeon or any doctor anywhere and get fixed. You cannot. Just like with a Formula One car. The Mercedes Formula One car can only be fixed and worked on by the Mercedes team. They know the parts, they have the parts manufacturing, they have the diagnostic tools to figure out what part's broken in the car and needs to be replaced. They have the technology to diagnose the problem in the car and fix it. They have the resources and technology to fix it. That's how Deuk Spine is. We are literally like a top Formula One team in fixing backs and neck problems, okay? And so you can't just go down the street and expect your doctor to know what I'm talking about. They won't. We are so far ahead in our understanding of back and neck pain than other doctors. We're literally, on average, somewhere around 40 years ahead. Hard to believe, but that is exactly the case. And if you think about other technologies in the world, you know, it's not too hard to believe that. After all, let's say you have an iPhone and it's broken and you're in the middle of Africa in the Sahara Desert. and you come across a tribe of native Africans, do you think they can fix your iPhone? Of course not. They don't have the ability to do that. They don't have the knowledge. They don't have the technology and resources. It's no different when it comes to spines. We've got to stop thinking that the people that can fix our backs and necks are everywhere. They're not everywhere. Okay? The technology has advanced so much in certain places, and it is so far behind in others. So don't expect everyone to be able to do what we do, because they can't. And don't punish us, because we can do what we do. Appreciate us. Support us. All right, first question.
First question comes from Terry on YouTube.
Hello, Terry on YouTube. Thanks for joining us.
They ask, how do you know that you have gotten all of the herniation out?
That's a great question, Terry. How do I know I've gotten all the herniation out? So, to answer your question, we never get all the herniation out. Nobody gets all the herniation out. It's impossible to get all the herniation out. That would be like having a sand in your backyard, and one day you say, I don't want sand anymore. So you go and take the sand out. How do you know you got every grain of sand out of there? Well, you can't. It's impossible. You already know you're not going to. No doctor can get all the herniation. That's not our goal. Our goal is not to get all the herniation. Any doctor that tells you they're going to get all the herniation is lying to you. It's impossible. Just impossible. Even if you had a dead person and you could go and take everything out and just leave the disc and scrape that all day long with a microscope, you're still not going to get all the disc out. It's impossible. Of course, in real life, we don't have access to the entire disc. We have little windows that we work through around the nerves, around the spinal cord. So it makes it even more impossible. How do I know I got enough out? That's experience. That's experience. That's what I do. And I've been doing it now for 17 and a half years, almost 18 years. We've been doing this endoscopic surgery. Over 1,850 surgeries. So how do we know we get enough out? Because I do it the same way in everybody, and the result is always the same. The pain is gone. Should I change what I do? I don't think so. I mean, there's an old saying, if it ain't broke, don't fix it. Yeah.
Next question comes from John on YouTube asking, once you have a tear in the disc, does it continue to produce herniations, or do you need to have some type of substantial injury for the herniations to continue coming out?
John?
John. Yeah.
John on YouTube.
Yep.
Hey, John, great question. So you have asked an incredibly brilliant, insightful question, in my opinion. One that I've pondered for years. And here's what I've learned. Here's what I believe is the truth. When people get an annular tear in the wall of their disc, which, by the way, folks, everybody with a bulging disc, herniated disc, slip disc, ruptured disc, extruded disc, protruded disc has a tear. You cannot have a bulging disc, herniated disc, ruptured disc, extruded disc, degenerated disc. If you have a perfectly normal disc, you don't have a tear. If there's anything wrong with your disc, you have a tear. The tear is always the first step. Now, our new website has some animations that I've been personally working on for a long time. And it's going to show you exactly how it works. But basically, here's what happens. When you damage your disc with trauma, you're basically tearing the annulus with a sudden force that rips the annulus. At the same time, it crushes the nucleus next to the annular tear and fragments it into little pieces. Now, the pieces don't come out through the tear next to them unless they're pushed out. That's where your regular bending, lifting activities, like you did something like lifted a piece of furniture, right? If you have a normal back and a normal disc, you can lift a piece of furniture. you're not going to cause a herniation. But when you have a tear and there's already fragmented nuclear material next to it, then lifting that piece of furniture is going to push out those pieces, okay? We see this all the time in work-related injuries. People that get hurt at work. They had a pre-existing tear, a pre-existing injury. Maybe when they were young, they got into a car accident, hurt their spine, but they had no symptoms, no pain, no need for treatment. And then they go lift a piece of furniture at work or something, and they spit out a piece of herniation. And that herniation now, that's the one, it causes symptoms. So those people have little pieces of herniation that aren't herniated yet. They're waiting to be herniated. They're in line right next to the tear, waiting for that force to push it out. And that's your bending, lifting, twisting, getting on a Stairmaster, whatever. Okay? So I don't know if that, hopefully that answers your question.
And this next question comes from Premier Media Group on YouTube, asking, how long after a DLDR should a patient wait until they can go snowboarding again? Asking for a friend. Also,
Right,
Merry
right.
Christmas to the whole team.
Merry Christmas, my friend. And it's great to hear you're a snowboarder. I'm a snowboarder. I've been snowboarding since 1980, 1982. 1982 or 83. So I've been snowboarding for 40 years. I was one of the original snowboarders in California when the snowboards first came out. And I gotta say, when I got on a snowboard, I used to ski before that, and I got on a snowboard and I never went back to skis after the snowboard. Now, I'll be the first person to tell you it was a very traumatic time those first 3 days on the snowboard. I mean, holy mackerel. The boards, the original boards, the boards back then, they slip out from underneath you so easily. They had no edge. And the way they were contoured, they were pretty much straight. And so they didn't have the right flexibility of the material. It didn't deform properly. So they were very stiff, very straight, with no edge. Man, you felt all day long. And I felt all day long on my butt. I literally hurt so bad at the end of the day that I could not sit in a chair. Literally could not sit in a chair. I mean, I felt like I had raw meat down there on my butt. It was so bad. Anyway, after about 3 days of falling and never giving up, I finally kind of got it. And I was able to do, of course, just the bunny slopes. Now, I do double black diamonds with my son on a snowboard. We go alpine skiing and snowboarding, and I love it. I just absolutely love my snowboard. So I get it. But you cannot go snowboarding this year, 100%. Okay? You need to wait you need to wait a year. Not at least a year for snowboarding. Sorry. I think skiing is different. If you were to ask me when can I go back on my skis, skiing is different. As long as you're not falling and jumping and moguling and alpine skiing, you can go back to skiing the blues, the greens, usually within 4 to 6 months after surgery with the Deuk laser disc repair. Skiing's not a problem because a good skier doesn't really fall, and you get your skis on without bending down or squatting or sitting. But a snowboarder has to usually sit or bend over to get your board on, and that's not good for your back yet. So wait a year.
That is it for questions.
All right, everybody, thank you. Been a great procedure. Our patient, I think, we've cured 22 years plus of back pain with this procedure. I'm excited for him. And our next surgery is going to be actually a cervical DPR for facets, which is going to be in the other room. And then we'll be back again for a nail biter. This lady we're doing next. It's going to be about an hour. I don't even want to think about it. It brings nightmares. She has horrible scoliosis. She's had a fusion of her whole spine except for the L4-S1. And she's got a herniated disc on the left side pinching her nerve, and that nerve is getting crushed. So I'm not looking forward to this one, but I will do it because she needs help. So that's going to be a real challenging case. Yep. Anyway, and then the last case for the day is a single level lumbar, DLDR. Another patient with bad back pain coming from a bad disc, one level. Have a wonderful afternoon if we don't see you. Happy holidays, and we'll be back after today. We'll be back in January.